Okay, so week 7, we're going to cover the introduction to chapters 7 and 8 in essentials. We're done with wellness, and we're going to do chapter 8 in tappings. So you have just 2 subjects, but we're doing the introduction only because this covers all of the bones and muscles, but we're not using this book for learning that. That's when we go back to Trail Guide. Okay? So I have noted on your assignments what pages we're covering. That's where we're going to stop, but just so that there's no useless studying and covering of the whole chapters. Okay? So starting next class, you will need your Trail Guide book again. You'll need both for just the next week or next class. You'll need both essentials and Trail Guide, but then after that you can leave essentials. And that's because we'll be doing the introduction to muscles and starting at the top of the body. But then after that, you can leave essentials home for like 3 months.
Or 3 months.
Something like that. I haven't counted it exactly, but don't quote me exactly.
When are we going to need our next set of books by?
If you click on the class schedule that's in the dashboard, you can look at the whole year's date, and I indicate when you need each book, when you need, ethics, when you need, It's all listed right there. Over a month. It's over a month out before we need another book. I think Hydro is the next book that you'll need, and that one's not expensive at all. Okay. So, chapter 7, we start on page 193 in your essentials book. So the skeletal system. So, just a reminder, kinesiology, it studies human movement. Okay, how to process the movement of all of our anatomy or all the parts. As human beings, and biomechanics is the principles of the structure of just human movement on its own. We as humans have an endoskeleton. That means that our supported, what's the word? It's structure, but I'm thinking of something else. Frame, yes, thank you. The frame that we grow around it. So unlike a crab or lobster, they have an exoskeleton, so they have to stay within it. When they outgrow it, they have to go get a new shell. They have to grow one or go find one. Thankfully, we as humans, we grow on the outside of ours, so we don't have to go finding new framework. Because some of us fluctuate. We save some framework, then we come back to it. Okay, so we grow around our support structure. So our skeletal system, we have bones and joints. The joints are also known as articulations. You see that a lot in your Trail Guide book. It's where 2 bones connect together. When the structures of both the muscles and bones come together, they are functionally known as the musculoskeletal system. That's important as well. The main functions of the skeletal system is supporting the soft tissue, being the framework for the whole body. It gives attachment points for muscles and ligaments. It protects delicate internal organs, which you've learned as a group are called our, I told you I was going to ask you again. Our internal organs, our vital internal organs as a group are called our viscera. See, you're getting faster every time I ask you. Great. Also, they provide levers so that our body can move. They also store calcium and other minerals that can release them when the body needs them. Stores lipids as well within the bone marrow, which we can use as an energy source when we don't have glucose and other more easily accessible sources of energy. And it provides blood cells within the red marrow part of the bone to help produce blood cells. So our bones provide a lot of functions. And that's why when we break larger bones, it usually lessens our lifespan because we can't produce our blood cells either as much capacity. They only last a couple days, so they need to be replaced often. So large bones like hip or femur are large blood supply bones, and so that's why you'll see a shortening of life in older people that break these bones. Okay. On to the main substance of the chapter. Okay, we have on average about 206 bones as an adult. We have as much as 300 as a child, as an infant, but they do fuse together as you reach mature stages. So even the ones that are fused in the spine are not fused at that point, and that allows for easier exit from the mother through the natural cavity. You need to squish around. Things that are not connected can move in and out much better, even if all the bones in the skull are soft and not one piece as they are. That way it can compress if needed and not break. So some people will have less sesamoid bones. Some people will have an extra rib here or there. There's a variation in how many individual bones, so there's just an average amount of how many each person has. And that's how we learn in this class is the general structure of an average person, but you can't expect the location to be precise for each person. That's why we learn ways to check on, especially angled muscles and things. You want to find their exact ones, you can work it specifically, especially when they have a pain or issue there. Bones are composed of osseous tissue. That word just is another word for bone tissue. Osseous and bone are used interchangeably. And bones are not this archaic thing. They're a living, breathing thing. As you see, since they're producing our blood cells and they are holding and producing minerals and fat for us, we can see that they are a living form of matter. 2/3 of bone tissue is made of inorganic material, and that gives us rigidity, which we do need. The other third is going to be organic matter, which gives us more elasticity. So you might not think of bones as being elastic, but they have a little bit of ability to move or vibrate against pounding, shock absorbing movements. And this quality is known as piezoelectric quality. It's how the bones or the collagen within them can reform themselves a little bit and vibrate as like an electric current passes through them, in order to take on a high stress load regardless of the direction that it's coming at it. So the patterns of the bone, how it's formed, is according to what kind of stress load is put on it. And that's why you'll occasionally see bone spurs and other growths on bones on an area of high pressure. So the feet is the most likely. Sometimes on the thumb area, you'll see it very likely. Occasionally other areas, depends on the person and what they're doing, what kind of workload that they're taking on.
Is that how tori forms in the mouth?
Say that word again.
I said, is that how tori in the mouth forms?
It could be.
Because I have
Okay.
lots.
Okay. See, I'm still learning about
I
you.
was told that it's because I clench my jaw when I sleep, so the pressure forces the bone to grow.
Have they given you
a mouth
a
guard?
protective mouth guard yet?
I chewed it.
Okay.
Yeah, so
Definitely yes.
yeah. So I can I don't mind if you guys wanna like look and see like an example
Okay.
of like what it is.
Okay.
It's just like a extra bone growth
Right.
and formation.
Was it a customized one from like?
It wasn't.
Yeah.
It was over the counter.
Yeah, that's not the same. I've had both.
Yeah.
It's not the same at all. Hello? Who is that?
Came from a big truck.
Can I help you?
I didn't know that was school, but I was trying to get a certificate.
Oh, come on in. It's okay. Take a
I'm sorry. I moved the hours online and it said till 7, but I didn't know you had
No,
a
you're
phone.
fine.
It's all, I'm still here. I need to get another phone number like tomorrow. Yeah, right. This was on the tail, like DAR.
Gotta give us stuff. No, this young
That's why
lady.
I was thinking.
I know.
It's that bad
It
stuff.
smells good.
You can use it
It does.
as
Yeah,
a
it looks like
or you can just
genuine,
put it.
real thing. You probably like less.
I did.
You did, didn't you? I know you did. It's so cute. I love it. Sentimental.
Just take a good deep set of therapy. That's like
You-
you
Yeah.
can use it in the shower.
Whatever.
Just dump the
It's
whole
all right.
thing in your bath water and just soak in it. It's
I'm
fine.
going to my friend about having a big hub, see, I've already decided, whoever made that hub, they are made from hell. Because those people that make bathtubs, do not make them for people that are my size. They make them like this.
I know.
I said, you do understand that people my size have to sit here and say, like this, and that. There is no kind of comfort to sit that way in a bathtub. I said, then you have to, have you ever read Medea? Have you ever read it? Okay, so, if you ever read the book, it's so fun. So in the book, she talks about how she has to Vaseline the tub. And so in order to bathe, she has to sit and Vaseline the tub, so when she goes to soak her body, she has to Vaseline the tub and then she has to do like this. And that's how she gets to soak her body, because I'm telling you, in a bathtub that's made like this, you got hips that are like this, that's pretty much how you have to go in here. So. Sorry.
No, you're fine. I agree. I'm not even, tall or big, and I still feel that way. They don't make them long enough.
Yeah.
Like, I want the whole thing covered in water.
The big
I
end
don't
is where,
want this part out.
yeah, the big end is where the spout is, and I'm like, well, that's not comfortable at all, is it?
Since we are on the subject of phones and
Uh-huh.
numbers, I was volunteered to, share your thing, but I have a condition, it's called Osgood slaughter.
Yep.
And
We're gonna
my-
study that in pathology.
Basically, my knees didn't fuse right, going through like a growth spurt, so I have like a floating bone. I've had one of them operated on.
Okay.
Actually, the other one doesn't give me issues anymore,
The operated one?
the one that isn't operated.
So the operated one is giving you issues.
No, not really. It's probably a little more tender, but it doesn't constantly hurt.
Did you have any, like, therapy after the surgery on it?
Yeah, like they did minimal therapy with me, and then of course I had to do stuff on my own, which I did pretty regularly, considering I was younger.
Right, okay. Understand. And, okay, well, that's cool. Yeah, we're gonna have all kind of stuff pop up. More stuff will pop up as we keep
That
talking
last
about it.
chapter had me a little bit paranoid, just like you think about all these symptoms, and then you have one little thought in your head.
A if that chapter got you paranoid, pathology is gonna make you nuts. 'Cause that's like a little appetizer. Okay. Okay, so let's talk now about the bone structure. All right. I saw that. I thought she was a badge on.
She already sent it to you.
She's in the uniform. Should be okay. All right. Bone structure. So we know it's rigid. We know that it helps. Normally, most bones will articulate with another one. Their connective tissue structure called the periosteum is what covers every bone except there's a couple little tiny little places where there'll be an exception, but for the most part that's the rule. The periosteum covers it, and think of like the perimeter for the beginning for periosteum. The structure and function of bones are very connected. As we just mentioned, the shape of them is there for a reason. It's the framework, and so how we use something is going to be connected with the shape of it. For a simple example, the brain, the skull. It's made to protect the brain, so the shape is to be kind of right outside the shape of our brain. It's not square and then the brain is oval with wasted space for it to slosh around in and get bruised. It's very close. And all the other bones are laid up that way too, like the fingers. They're little short bones made up like long bones for bending and for good tensile strength. And you're gonna learn each one individually as we go through the course. But the skeleton itself is a very dynamic system of the body. And let's go through the different types of tissue that it has. We have dense or compact bone, and this is usually the main shaft, which is the mid portion of the bone, so not the ends but the middle. The shaft is what we usually refer to on long bones, like in the thigh, in the arm. And the outer layer of all bones is the hardest portion of compact bone. It protects the spongier bone inside, and that makes sense to have the firmer surface on the exterior. Spongy bone is also called cancellous bone. It has a less dense matrix, so there's more space, so it makes it lighter. So we're not dragging around big, thick, But if you think about, have you ever, gone to a hardware store and you see the steel poles that are hollow, and you see the one that is completely metal? If you're not looking at it and they're just standing there, they look the exact same. When you go to pick it up, you can tell which one is hollow and which one is thick all the way through. So our bones are not hollow, but they have a lot of spaces within the spiderweb matrix within the bone. It still provides strength, but it's not so heavy for us to look around. Okay. So it's more lightweight, and it's irregular meshing. There's no exact way that this framework is. Everyone's gonna be a little bit different. But this is where in the trabecular space, here at the ends of the long bones and in the shafts, this is where the blood cells are produced. And in the bone marrow, we have red and yellow. The red is what manufactures our blood cells. At the ends of the long bones is where this is found. And at the center of larger bones in the pelvic and thorax region. And yellow marrow is mostly made up of fat or adipose tissue, and it's in the central cavities of all of the long bones of the body. You didn't think you had fat in your bones, did you? Okay.
That's why I'm big boned. That's it.
All right, periosteum and endosteum. As I mentioned, the periosteum is the covering for the bones, except for the ends that form joints. That's the exception. It has a different cover. And there's a thinner membrane within the marrow cavity in the center called the endosteum. And this is where we can repair tissue, bones, when we have fractures and things, and allows them to grow. And we have a nice picture on 196 that kind of outlines what we're talking about. So we have this more spongy matrix here in the middle, outline this marrow cavity, and we have the more compact bone on the exterior portion of the bone. And you can see the periosteum that is right on the outside is littered with blood vessels and veins coming off the bone, and that's because we're creating blood cells right within the bone here. They get sent out to the rest of the body. Okay. And then it gives you an inside look at the compact bone level here, with the different lamina and the Haversian system, and the little canals where all of these vessels are coming in and out within that. So when you go and keep zooming in, you can keep seeing more detail. So very organized. All right, so moving on, and that's another view kind of the actual microscopic view of a live bone that they've cut here. So it doesn't look too far from the sketch on the other page.
It looks like the circle, like when you cut a tree trunk.
Mm-hmm.
That's like how our body correlates with everything in nature.
Yep.
It's really the same.
We're part of nature too. We just separate ourselves a lot. Not for beneficial usually. Okay, now we're on to bone development on 195. So ossification. We already talked about osseous is what bone tissue is. Ossification is building bone. The process of this happens. And this happens by depositing calcium salts within the tissues. And then it calcifies or creates bone by using chondroblast or cartilage, which is a kind of a temporary model for what the form is going to look like. And then the osteoblasts come in and develop that bone tissue around that model. So it's like, here's a temporary, playhouse, and then here's the actual real thing. And of course, so you do need to know chondroblasts and osteoblasts and what they do. After birth, our cartilage starts to harden a little bit, and this is called osteogenesis. This is the depositing of those calcium salts into that matrix so that it can form hard bone. Because we've been floating in fluid up to that point. We need any hard protection. The mother was doing it for us. We come out into the world, we're going to start eventually moving, and then by that point we need hardened bones. And that's why there's a certain point where they say, don't encourage your baby to walk too early because the bones are not firm yet, and it'll cause them to bow and bend instead of be straight. Okay, articular cartilage. Cartilage is a nice flexible connective tissue, and when we're an adult, we don't have a lot of it. We have a whole lot of it as a child, but as an adult, we really only have hyaline cartilage, which is a smooth, very malleable tissue that doesn't have any blood vessels in it or nerves in it. It allows the bones to move each other very freely, and it's found wherever bones come together in our articulating, moving joints. It creates synovial fluid, and this fluid is what allows these hard surfaces to slide through each other. Another reason why we need to be hydrated. It's made up of a lot of water. We don't have a lot of water taken and used for things like the heart and brain that need it more. So synovial fluid provides a lot of oxygen and nutrition also to the joint. And when we massage joints and move the joints, like we're going to do tonight, this helps stimulate synovial fluid production. So simply massaging somebody's joints is going to help their pain. Like I had somebody who didn't tell me till after their massage that, and I just did it as part of their general session. She got up and told her friend as they're checking out, well, I'm glad I came because I'm having knee replacement surgery in a couple days and my knee's not hurting now. You didn't tell me that you have knee issues? But I did all the friction stuff around her knees because she's an older person. And so that created synovial fluid that was probably not there, and so it was allowing it to move instead of grind on the bone. I was like, if you had told me that, I would have done a lot more. Okay. Ligaments, page 197. These are made up of collagen mostly. They are laid out in parallel fibers. Ligaments connect bone to bone. They stabilize joints. Some of them are attached by muscles. Some muscles will attach to the ligament, not to the bone. They do not stretch very much because they're made of collagen, not elastin. So that, like I told you a couple weeks ago, when you're palpating and you're not sure, you're probably on a tendon. If you think you're on bone, but it moves a little bit, you're on a ligament. It'll be very hard, and the stiffer the person is, it will feel like bone. Okay, but if it doesn't move with something, then that's a ligament. All right, bone classifications. And because they don't have a lot of, veins and blood flow, vascularization, that's why bones take longer to heal. Bone growth, classification. So we have long bones, short bones, flat bones, irregular bones, and sesamoid bones. We already know what long bones are. We've been over that. So short bones are like in the ankles and wrist area, kind of boxy shaped. Long bones are going to have two ends that articulate with a long shaft in the middle. Long is very relative, okay? You can have long bones that are multiple feet long. You can have long bones that are a couple inches long, but they're still going to look similar. Flat bones are flatter than they are round, and that's going to be like your ribs, okay? And skull bones are also called flat bones. Irregular bones do not have any kind of similar shape as any other bone, and that would be like in the scapula and in the vertebrae. They don't have really a shape. They have their own unique forms. The pelvis? That is, I think. Well, the pelvis is made up of like six bones. So there's going to be different shapes there. So we'll learn those. Sesamoid bones, they are round bones within soft attachments like the patella. It does not attach to any other bone. It's just attached by ligaments and tendons floating around. Okay, so it's kind of an irregular bone because it doesn't fit any other of the other three categories. Okay, now bone growth and repair. Our bones grow the fastest during puberty. Big surprise, right? We've already seen those in our lifetime. Shoot up a couple inches in a couple months. They will widen and lengthen over time as necessary. We have epiphyses, which is a secondary bone forming center, and they can continue. That's just kind of the spot, the area where the bone can continue to grow, even possibly outside of puberty, hormonal growth spurt changes. But so the growth plate is there at the epiphyses or the epiphyseal disc. Typically, as females in our teens, boys generally by their early 20s, our growth plate closes. It's done growing height-wise or in length. But we can grow in width. Now, when we get past a certain stage in life, then we can start reversing in height. We can start losing some height. We get thinner bones that are not as substantial, I'll say. And we can get weak and brittle bones from lack of those minerals being there, as well as we lose collagen and some of the other structural components of the bone. It's easier to fracture them. We have less blood flow. It's not as good. And so they've been slower to heal. They're easier to fracture and break. They don't have all those nutrients at the ready. You're not sending the nutrients as fast either. You're less flexible, so you're usually less likely to heal completely and well at that point. And we'll talk about, disc and stuff of that nature later on in a second. Fracture healing. That's discussed a little bit. There's different forms or phases of it. Hematoma formation, talking about with the blood. Cellular, bringing in cells to help clean up and bring nutrients. Then we start the modeling process with the collagen, and then the ossification, adding those to harden the new area, and then remodeling it for use according to what pressure is put upon it. Okay? As we age, we're still on 197. Around 40, you start, your bones start thinning a little bit, and you lose about half an inch of height every 20 years at that point, on average. Your ribs start calcifying the cartilage where it connects together. This cartilage here. And so that reduces the flexibility of your rib cage, which is going to affect your oxygen levels. All joyous stuff, right? So that's the other reasons why we need to be helpful for older people. Be aware of, what the changes are in their body. Try to assist where their body is lacking, but also do it in a safe way. So deep tissue on an older person that wants deep should be different than deep tissue on a younger, vibrant, or athletic type person. Mm-hmm. Still deep, but modified just a little bit for their safety. Even if they're not the happiest about it, it should be fun. You're not trying to harm their body and bruise them up and have them have a 3-day recovery from your massage process. Okay. So it's very important that we learn. There's the shapes that needs to be moved. The different body parts, because we're going to be learning the attachments of the bones. So here are the terms for different areas of the bones. So we'll have canals, fissures, foramen, which is an opening or a hole. Fossa is a depression at the end of a bone. So just a little dip, okay? Grooves, those are a depression with a purpose for a blood vessel to come through, or a nerve. Or to pass by, I should say. Like a little groove, a little dent in the bone that is there for a particular vessel to be able to fit through. Such as in our elbow, right? There's a little groove for our ulnar nerve to pass through. There's other ones we're going to learn about. Meatus is a tunnel. A notch is an indentation or a larger groove, and they typically have a different special name for those. And a sinus is an open space or air cavity within the bone, most commonly found in the skull. Okay, so those are depressions and openings terms. Next, we have processes of the bones that actually form joints. So those are going to be where on the bones? On the ends. Very good, because that's where the ends of bones is where joints form. Very good. So a rounded part sticking out or projecting from the end is called a condyle. A rounded projection that's at the top of a bone is called a head. The head will always have a neck under it, so we have a little straight spot with a rounded end. That's going to be a head and a neck. You always have both together. Facet is a smooth, flat surface. Those are mostly found on the vertebrae or ribs. Processes, these are some kind of little piece sticking out. Have them all along the vertebrae. Those are called your spinous processes. That's what you call your spine for right now. But in a few weeks, you will not call it that anymore. And trochlea, this is a special pulley-shaped structure only found in one or two bones, humerus being one of them. Okay, next we have processes where tendons and ligaments attach. Epicondyle, you'll see several times. This is something coming off of a condyle. You're always going to have a condyle and an epicondyle. You can't have an epicondyle without the condyle. It has to exist first. Just like you can't have a head without a neck. It's called something else if there's no neck. What is it called if it doesn't have a neck? I taught you this 2 minutes ago. It's a condyle.
Condyle.
So if it's a condyle with no neck, it's not called a head. It's called a condyle. All right. Spinous processes, we just talked about that, but on some other bones it'll be called a spine of something, such as on the scapula. Trochanter, again, this is a special term for your femur bone. It's a large process off of the femur bone. Tubercles, these are small round processes. And what's a process? It's a small growth sticking out of a bone. Yes, they are on the spine, but they're going to be in some other bones too. So the spinous process is on the spine, but there's other processes you'll see somewhere else. And tubercle and tuberosity. So, yay, these are all your spinal terms. Get familiar with them this week, okay? That's why we're only doing the introductions, okay? I used to do all 3 introductions in 1 week, but I found out that was a little bit too much information for 1 week, so now I have it separated. Okay, we're also gonna just briefly talk about, again, the division of the skeletal system. What is found in green? What's that called? Axial. Because the head turns on an axis. Maybe that will help you remember that part is called the axial skeleton. And everything in yellow is the appendicular. They are appendages, including how they attach to the axial spine. So it's not just the leg and arm bones, but also the pelvic bone, also the scapula and clavicle is included. Okay? All right, so that's the introduction to chapter 7. Now flip over to chapter 8, and we'll do the introduction to that, joints. It's on page 235. All right, so introduction to joints. Again, as I've mentioned, a joint is AKA articulation. And the reason why we need to know our jointed areas as a massage therapist is because it directly is part of the structure that we're going to be affecting. So a joint cannot exist without its parts, which are 2 bones, at least 2. Sometimes you'll have more than 2, sometimes you'll have a third. Typically joints are passive without the muscles that attach to them, because that's how they move. The muscles move the joints. The joint is just there for framework. Don't forget that. So they have to depend on each other to be able to move our body or our organism. Okay. The joint can provide stability and mobility by allowing the muscles to move it. All right, so the forces of how we have stability, the shape of the joint, how it fits to the other parts is very important for the stability. The amount of closure will affect how much the muscle has to contract in order to help the joint stay stable. They work together to protect us from breaking and fracturing and tearing. So the stretch reflex we learned last week, why is that there? To limit the amount of pressure on the joint. The muscles start sending the signal, we need to slow down this movement because we're almost at the end of where we want to happily go. After we force someone to go past their happy point, they have some kind of volume come out of them. Sound, right? Ooh! This is how far I stretch. No, you can go this far. We make a sound in our body. We're fighting the natural stop point. Now, of course, dancers and ballerinas are going to stretch to try to do that all the time. But it's not what a normal person enjoys as a hobby. So, the force and the form work together. If we have excessive form, then we have a stuck joint that will not go through its normal range of motion. If we have excessive force, it can jam the joints together, so we don't want that either. So either one can strain either the joint or the muscle. So we're trying to have a nice balance with when we're working. All right, connective tissue, we're on 236. Connective tissue is used to form our joints, all the parts that make up, even the membranes, the tendons, the discs and bursa in between. We have connective tissues. We learned there's all different types of connective tissue. We're going to go into them a little bit more tonight, the different types. The matrix has extracellular matrix or ground substance, kind of gel-like, with a fibrous component, so kind of very thick gel type structure. But there's two types of fibers, collagen and elastin. Collagen is white fibrous tissue. Has very strong tensile strength, which means to withstand force and not break. It is non-elastic, so it has very small amount of mobility, but it does have that piezoelectric property like the bone has, okay, against that force to be able to deform itself a little bit in order to protect the structure. So it's going to be more rope-like when you feel collagen type tissue. Elastin is yellow fibrous tissue, and it allows more stretching. It's more elastic, so it can stretch more and go back to its original shape much easier. So the more collagen that something has, the less flexible it's going to be. The more elastin properties that the structure has, the more mobile it will be. Like a rubber band. Okay, joint capsule. This is what is the fibrous tissue attached to bone. It is a sealed sleeve around the joint. So that's what you can think of, the joint, and then this little protective covering is what we're talking about. So we're talking about joint capsules, everything that composes the joint, not just the bones, okay? So it's going to give a little bit of stability to the joint because it can only move within that capsule. It cannot move outside of the capsule. That will be called a break, okay? So what will allow it to move without harm, okay? And we're going to get further into that later in the chapter. Okay, ligaments is next. They are made up of 70 to 80% collagen. So that means that they are very elastic? No. They're there more for structural stability. Okay? Avascular, does that mean they have a high amount of blood vessels or a low amount? No. Like abnormal and normal? Avascular versus vascular. Vascular means you have a lot. Avascular means you have a little bit. Tendons. They are similar to a ligament, but they connect muscle to bone, not bone to bone. They're a little bit more vascular than a tendon. They're basically like a sheath, a double layer of it is called a sheath. It's for protecting and helps to reduce friction around the joints. They do help stabilize them, but they limit the range of motion of the joint, of course, within that capsule we talked about. So all these structures are there to allow function within the safe range. Okay, bursa is next. These are flat sacs of synovial membrane. We talked about synovial about 10 minutes ago. What does that do? It lubricates the joints. So a sac of that fluid, what do you think it does? It helps cushion the joint. That's very good. And they are around any structures that are going to move and rub on each other. So, like a squishy Band-Aid. that has gel in it. If your shoe is rubbing your ankle, you might put one on there for the rest of the day. You didn't realize your new shoe is going to make a blister. So your body creates a Bursa-like sac there when you don't have it there. A little sac of fluid, what a blister is. So this is there around jointed areas. Moving parts are going to hit each other to keep them from hitting each other. Okay? So that's what a bursa is there. Reduce friction in an area that needs some cushioning. Cartilage, 238. There's 3 different types of cartilage. We have white and yellow cartilage as well as hyaline cartilage. The white cartilage is going to have more collagen fibers. The yellow is going to have more elastin fibers as their color, and that's going to provide more flexibility. The white is going to limit motion but provide more stability. Hyaline cartilage is going to be on the thin covering of the ends of bones. So now you know what covers the ends of bones, right? We have one coverage for most of the bone, and we have hyaline cartilage for the ends where they articulate. Okay. The reason why we have this special cartilage on this surface is because it provides very low amount of friction with the movement, and this is on the movement area of the bone, and so it needs that. It's very good for distributing weight over the space, and so that's why it's there on the end of bones that are going to be moving and especially be weight supporting during that movement. All right, bone is next. This is the hardest connective tissue that we have in the body. Very strong matrix, fibrous components. It does have ground substance as well. All connective tissue is viscoelastic, and this just means that it can return to its original state but be resistant to change. Okay, so combining those properties is what viscoelastic means. Let's see. So areas of the body that are consistently under pressure, they want to take that force, but they're trying to go back, stay back to their original shape or location. So the ability to do this is called creep. So slowly go back to your original state. To creep. So you could be deformed for a long time and slowly go back. If you do not get to go back to that state, it takes too long for that to happen. It may not be able to do that. So if something is, let's say you stretch a rubber band for 5 minutes, it can go back to original state. If you stretch it out for a week, it may lose some of its elastic nature and just be soft, and it doesn't go back, right? It goes, but it's like a time and a half bigger than it was originally. Same thing with these connective structures. If we are under this force and unable to go back within so much time, that change could become more permanent within the tissues. It's weakened it to the point that it's not able to retract all the way back anymore. And that will alter the function of the joint wherever that happens, because it's not going to be able to go back to zero. So I'm gonna go back to 10 or so, so that's going to limit a little bit its range and its strength. Okay, plastic range. This is when we have exceeded the elastic limits of that tissue. And we've permanently deformed, it can no longer go back to its original state. When this occurs, we usually have a tear or a break in the structure. When that's permanently deforming the structure, not going back to zero. When it's a ligament or a tendon and we tear it, we call it a rupture. When it happens to a bone, if it's the part where the ligament attaches it to another bone, it's called an avulsion. That's because the ligament is not affected in that case. It's just the bone. If the bone, the failure happens in the bone, it's called a fracture. That's bone-to-bone break or tear. Okay, laxity is next. This is when there's too much stretching or trauma happened too long. We'll get laxity within the bone structure or matrix. And we can help a little bit with supporting compensation patterns when stuff like this happens. By trying to strengthen the muscles that are needed now to stabilize this new way that has to happen, because this is a permanent change. So we can't try to make it go back. We have to realize, okay, the support muscle is now having to take over most of this work. It's supposed to be a helper. So we need to help strengthen this muscle, because we can't rehab this back. So let's make this stronger. So in that case, then we don't want to lengthen that muscle, because that's going to weaken it. We have to strengthen it and work perpendicular. So there's reasons why to know what works with what. And the more medical setting that you're in, or when you have an injury occur in a client, that's when you really got to pull out all your medical knowledge. Okay, shortening. This is when the tissue shortens and it becomes dehydrated. So that one's pretty self-explanatory. But the body will have to alter its positioning for a little bit, or that could happen. That can happen just from, like, let's say that even like maybe a cashier who's standing all day, and they hike their hip on one side out of habit, but now there's a new job and they're doing that for 8 hours, and then they leave the job and they're limping, or they look like they're limping because they shortened this hip all day and they lengthened that leg all day. And so now when they step off their little cushion, the legs are not hitting the floor evenly, and they're, oh, I got a stretch. Mm-hmm. Or you've been driving for 10, 12 hours, and you get out, oh my God, oh, I can't take a full step. You see the people that rest there going out and they're not walking normal because they've shortened the muscle temporarily. And hopefully they stretch. They don't just go to the bathroom and get right back in the car. Hopefully they stretch and walk around a little bit and get some water. So we can kind of work with checking out the plastic range of their tissue, their stretch reflex response, and things of that nature. And we'll see that in the joint mobility things that we do tonight. Okay, mechanical forces. Compression is the first one, page 240. So compression forces occur when two structures are pressed together. So we already learned compression techniques last week, and that's what we were doing. Now, we're not trying to bruise the tissue, okay, going as hard as we possibly can, but we can use it to stimulate nerve function, to support circulation, a pumping motion, if you repeat it. It can help with connective tissue pliability. It is warming up the tissue in a more broad way. So this has a more broad contact point. Tension. This is when two ends are pulled separately. So we'll be doing that tonight. We will be applying what we call traction force on the joint structures. And this helps get them in alignment a little bit. If they're out of alignment, it can help to pull them evenly. It can also improve the pliability, again, of connective tissue. And there can be also injuries, and that's listed as first, second, and third degree, depending on the severity level of the injury. But we won't be doing any injury in our application. We'll be doing mild tension. Bending, mechanical force of bending. This would be such as kneading, will be it's kind of a compressive force with a tensile application. But kneading is part of that. We affect the ground substance of the tissue as well as the viscosity. And the proprioceptors get activated in both the muscles and tendons, and they have to respond as we are applying the pressure and then taking it away. Shear is next. This one is a sliding force with friction. So cross fiber friction going against the grain of the muscle, specifically to create inflammation as a therapeutic. With a therapeutic goal. So, cross fiber friction, we learned last week, it helps to break up adhesions. And so that's going to we're bringing in inflammation to help heal the area, because that brings in more blood flow, more white blood cells with nutrients, so that it can heal the tissue faster. And then we have torsion, which is a twisting force. That would be like horizontal stroking, for example, when we're going against each other, the hands. Sometimes kneading, just depends if we're doing it. Alternating kneading. And this also increases the pliability of the tissue. Joint categories. We have 3: synarthrosis, amphiarthrosis, and diarthrosis. Non-synovial, very limited movement is synarthrosis. Excuse me. Amphiarthrosis is slightly movable, a little bit more. And then diarthrosis is very freely mobile. Most of our joints that we move are diarthrosis, or synovial joints. They have that synovial fluid around them. So let's talk about the different categories. Synarthrosis on 242 is in fibrous joints. They are bone-on-bone connections. There's different types. A suture is the first one, found in like the skull bones. Very dense and fibrous. The periosteum of both connects, so very little movement. And we're talking about in adults, obviously, not in infants. Gomphiarthrosis. I'll just leave that for now. Gum arthrosis is peg in a hole, like the teeth sticking down in there. And they have to fit together, so it's got to fit into either the mandible or the maxilla. Syndesmosis is articulating bones joining together with like a ligament. So that would be like the two bones in the lower leg, the tibia and fibula. There's a membrane between them, as well as in the forearm. You have that in both. This membrane allows, a good amount of movement, but it limits how much that they can rotate. Okay? Alright, so amphiarthrosis is next. These are cartilage type joints with some mobility in there, much more than the previous one. Symphysis is first, and that would be such as in between, like a more fibrous disc, like between the hip or pelvic bones and between the vertebrae and the back and the spine. So there's hyaline layers of cartilage between the bones with this disc or plate in between. And then synchondrosis is that hyaline between the bones, such as in the end plates here, separating the growth plate from the middle shaft of the long bone, as well as here in the ribs, the cartilage between the bones with the ribs and the sternum. Okay. Diarthrosis is the third. These are synovial joints, very freely mobile. So you're going to have a fibrous joint capsule enclosed, surrounded by a synovial membrane, which is all around the inner surface of the joint capsule, so that it's cushioned with that fluid, freely movable, with as little friction as possible. And of course, hyaline cartilage will be outlining the ends of both of those articulations. So it's showing you the knee because that has the three bony structures. And you're going to have that hyaline in green. You have the bursa here all around. You have more bursa behind and between. You have the adipose tissue also for some cushion. You have meniscus, which is special in the knee. So lots of cushion for these weight-bearing articulating surfaces. Okay, so more in the joint capsule as promised is in this section here. Hold on. Okay, so 244, you have the outer layer and the inner layer. The outer layer is called the stratum fibrosum. You see that? Okay, and the inner layer is called the stratum synovium. So we have very dense tissue, fibrous tissue, adjoining the bones on the outer layer. Does not have a lot. It's avascular. Okay. But it can detect all these tension forces that we just talked about, compression, torsion, all that stuff. It's there to detect that, so it can respond very rapidly. So that sensory information is what it's trying to get from the skin and those structures there. The inner layer, the synovium layer, very well vascular system. It doesn't have a lot of sensitivity for that sensory information. So it's there to respond to hot and cold very quickly, so that it can either bring fluid or take it away. So that synovial fluid is there, and it's a thick, colorless fluid, lubricating the joint, very, like egg white, sort of. Lots of nutrition, lots of lubrication, that's what it's there for. So they both have their own function, the opposite function, so they can respond to each other for the needs of that joint. So that is what takes up that joint capsule besides just the bones. Okay, and then let's go through the motion of the joints. Arthrokinematics. This is movement of articulating surfaces of the joint. So they're going to be at the ends of the bones meeting together. Those movements particularly. So rolling, sliding, spinning, depending on what shape is articulating against another is how it's going to be described, as pictured there on 245. So sliding is like gliding, one over the other. Spinning is rotating, and then of course rolling is going on round and over on top of each other, like a bowling ball onto a flat floor. Joint play. These are little movements necessary for the joint to work correctly. So we talk about play in a steering wheel. It'll move a little bit. That's not what we're talking about really here. This has to happen because everything's not going to happen exactly at the precise degree. There's going to be a little bit of give and take that's necessary. So we have about 1/8 of an inch play in each joint for the human body. So we may say, okay, this joint can move up to 45 degrees. Well, it's going to have a little 44.8 and 45.2, and everyone's going to be a little bit different, but that's on average what's expected for this joint. And it may be able to go a little bit sideways rotation, so there's going to be a little bit of play in it, and that's going to be able to respond to those extra forces and little vibrations that it needs to be able to do within its range of motion. If we have too much play in a joint, that's going to be an unstable joint. Right? Like when you get a brand new car, there's no play in the steering wheel. It just turns. It doesn't do this. Yeah, if it does, you take it back. It's not brand new. Or it was not installed properly. You get a used car, you can't let go of the wheel because it's going to veer one way or the other. So we don't want our joints doing that. But if we don't have enough play in a joint, then we have too restricted of motion. If it can only, move, it can't move a little bit more, then that's restricted motion, and you'll be able to tell that. So this is this will be involuntary movements that we're not controlling. It's not about what the muscle's doing. It's just for proper function of the joints. Okay, next category, still on 245, osteokinematics. This is movement of the bones because the muscle did something. Okay? So what we just talked about was just the bones moving because of what they needed to do. Not about muscle movement. Now we're talking about muscle movement, so osteokinematics. Because remember we talked about the prefix arthro 4 weeks ago, and it meant what? Something to do with bones. Osteo means bone. Arthro means joint. It came back. Look at there. It didn't take very long. Okay. And we know kinematics is the study of movement. So joint movement, arthro is kinematics, osteokinematics, bone movement by the muscles. Muscles move the bones. Okay, great. Okay, so range of motion is the amount of movement available for this particular part that we're talking about. And there's always a number that we expect based off of what joint, how old they are, and then other factors, disease, trauma, injury before. But, 0 is what the anatomic position is. And then from where we move from there is going to be the amount of degrees measured. Okay, so the anatomic range of motion is the amount available within the structure's limits naturally. And the physiologic is the active range of motion. The pathologic is when we're not within, we can't reach those normal number ranges, or it goes too much outside of them. So pathologically, you can have hyper or hypomobile joints. And so we'll learn if some of you have some of those tonight in this class. Okay, so what is hypomobility? It means that there is a restricted amount of joint movement based off of the softening of the soft tissue structures around that joint. The ligaments and the tendons and the cartilage. Okay? Hypermobility is the opposite. It's going to be we're exceeding the limit. It could be a little bit unsafe. Not always, just depends. But it can be unsafe if you're going into those areas and it's under a weighted situation, because then those natural reflexes are not slowing it down. We can keep going. See, it's not going, we need to slow down because we're going to drop this heavy thing. Depending on what the joint is that has the hypermobility, right? Anyone have, I forgot, hypermobile fingers, thumbs? Somebody said that. Okay. So you just have to be aware of that when you're going to go into a more deeper pressure situation, so you protect your joints mentally, because it's not going to do it for you involuntarily as well as someone who has the natural stretch reflexes working. Okay. Infield. You will learn tonight a lot about infield on somebody other than yourself. We know about it for ourselves. We're like, oh no, that's enough of a stretch. We're going to learn about feeling it on others when we're applying it, how to tell so that you can work without really having to ask because you already felt it. You can check in if you're not sure. Or sometimes someone will want you to go past their natural because you're helping them. But we got to have that permission. So the 3 infields are bone, or soft, hard, or bony. So bony is going to be a bone stopping you, like on the elbow. We don't need to go past where their bone stops you on that one. A hard infield is going to be more ligament based, and then a soft infield is going to be more muscular. The hard is going to be more tendon ligament. So a more capsular feel is going to have a slight give. If there's dysfunction, though, then you'll have a restriction based off the joint capsule, but we'll get all into that. But a bony or hard infield is going to be a very shortened movement, like stop. Instead of a soft is going to, like you're gradually putting the brakes on. Yeah, I feel it's not letting me move it as easy. You know, when you're within the range, it's moving nice and quick, and it starts slowing down. Hard infield is like, that's it. And injury is going to, repeated use their muscles will start doing it before the endothelium kicks in anticipation of pain. And that's when you really have to say, let go. Let go. Let me hold your arm, because then your muscle won't try to stop me, because I will be doing all the weighted movement. The joint will be having a nap, and nothing's going to hurt, because I'm moving it for you. But if you don't let me move it, then you'll have the pain. That's the whole psychological aspect of it. So you spend a lot of time getting them to let you hold it. And we'll see that in here tonight, I'm sure, a couple times. Okay. Joint positions and stability. There's closed packed and loose packed. All synovial joints, which are the ones that we can move voluntarily, have one way that the surfaces fit together for best or most contact. That's called closed packed position, where the joints have the most contact between each other on the bony surfaces. It's also called the locked position. This offers the most stability for the joint, the closed packed position. It doesn't allow movement, but they have the most stability. Now when a joint is in their loose or unlocked position, you have less contact between the bony processes. But the movements can happen, that the surfaces that we talked about, rolling, spinning, and gliding. Okay, so there's closed, loose, and then there's least. Least is when it has the most laxity, and this is when they usually have inflammation, and more synovial fluid comes in. There'll be swelling. It'll be in a discomfort, relaxed position. So that's normally in an injury situation. But in a normal situation, you have closed and loose. Okay. Planes. You see these again? They're named for their what movements occur within them. Frontal, transverse, and sagittal. Coronal plane is which one? Frontal. Divides the body into front and back parts. Also called anterior and posterior. Yay. Okay, so back table can answer the next question. She got that one. Transverse planes divides the body into what parts? We need anatomical words. Not top and bottom. You got one of them. Okay, we got it as a group again. Superior and inferior. Good. And then sagittal divides the body into somebody else. Somebody else.
But it's not equal, right? It could be like here or there.
Yes, and now I need anatomical terms. I know you understand the concept.
Mm-hmm.
But here and there won't be on your answer options.
It's, I
That's the plane we're talking about. Yep. Divides it into, come on, Courtney, help her out.
It's horizontally across the midline.
No, that's transverse plane. We did that one.
Oh, wait, which one?
We're doing sagittal.
Oh, it's, laterally and
Yay,
Oh.
see, good. So we got it as a group. That's good. That's step one. We get the concept, we get half of it, and then next month I want one person to shout the whole thing. Okay, good. Okay, so, then we got pronation and supination. That's where prone and supine come from on the table. Abduction and adduction. That's moving how?
To the middle and from the middle.
Yes. Which one is abduction?
Abduction is away.
I knew you were gonna get it. Abduction. Remember, it got taken away from the family. It got taken away from the body. I was waiting, like they're saying the wrong answer. She's gonna get it.
I got that one.
Okay. What about deviation?
Moving down your chin.
Okay.
Mandible.
You're thinking of a different movement that rhymes with that. Well, wait. Yeah, you can deviate here, but you didn't say it correctly.
I deviated septum.
No, we're not talking about breaking stuff.
Chin.
Yeah. I'll let you say chin one more week. You're gonna learn the name next class. Maybe 2 more weeks. But anyway, okay.
Deviating from the normal.
From the midline
Right.
is what it is. So in your normal position, you deviate to the side. That's mandible deviation. There's also radial deviation. But anyway, and then we have plantar flexion and dorsiflexion. Different movements that occur within the plane. And you have a lovely box on 249 that has all of the possible movements that you should be familiar with by the next time I see you. This is not the first time you've seen these, so don't act like it's new. This is like the 3rd time that you've seen this. We saw it in chapter 2 of this book. We saw it in chapter 1 of Trail Guide, and now it's a review in chapter 8. So if any of these you're not comfortable with, just look at them again. There's a couple new ones like iliosacral motion, counter nutation. Let's talk about pelvic flexion. The pelvic tilt names, I'm not asking you to remember those. We'll cover those when we do the pelvic bones. That's at the bottom.
You should have started with this chapter first. This would have helped.
This is in your trail guide. This is in your trail guide book.
Wag your tail.
With pictures. So it's just spread out. Okay, pictures are coming up next in the next couple pages. Okay, so, and here's your answers I just asked you about that you guys have lovely went over. See? It's going to stick more when we do it that way. Divides the body and allows what kind of movements. And there's all your movements. That's on your table on 249. Well, you're not going to worry about nutation. We're just going to call pelvic tilting. So you don't have to learn those. Okay, so then we measure in degrees of, what degree can somebody move in? What's the expected normal range of motion? Okay, now I'm not going to have you memorize all these degrees. Everybody say, yay!
Very much so.
So, there'll be some that I want you to be familiar with, but I'm not going to make you memorize like all the degrees. That comes later in chapter 10 of Essentials, but that'll be 4 months from now. So you just let that go.
We did do that when I had to do physical therapy for my knee.
Yep. And when you have that knee replacement, you're like, I don't want you to push it back. But you need that for your natural motion. Okay, so back on 250, we have uniaxial joints. This is joints that only allow movement in one plane or one axis. So a hinge joint and a pivot joint are a uniaxial joint. So hinge joint is like the elbow or the finger that allows just flexion and extension. A pivot joint can rotate around a bone, such as our head pivots or you may have called it turning, but you now call it pivot, because you learned that 4 weeks ago, and you know that that is what we call it in here now, pivoting, okay, which is rotating on an axis. Biaxial joints, condyloid and saddle, these are allowing movement on 2 axes and 2 planes. So condyloid or ellipsoid joint, as it's called, like in the wrist, you can do your abduction, adduction movements in the wrist. You can also do your flexion, extension. So those are in 2 different planes. Which planes is movement in adduction, abduction? You can get it. Transverse plane. You can't cross over the plane. See, this would be crossing over sagittal. Transverse cuts it this way. See? And also, it allows movement in this plane.
If it's crossing from the left leg, it's not in the front.
We're not counting the other movement. We're saying it allows it in 2 axes and 2 planes. You see, if it could only do flexion extension, like the elbow, that's only happening in 1 plane. Don't worry about it yet. I was just seeing if you remembered. It was just on the slide.
I never can do it the same.
So sagittal is flexion extension. It's staying in the interior part of this plane. See, it's not going back here. Frontal plane. But I don't really focus a lot on that. It's helpful if you can remember that, but it's not a life or death situation. So if your brain just go collect the pieces, put them back in the bag, save them for later. Okay. Okay. My physio teacher was like, he went 4 hours on it. So. Yeah, we had questions on that. I don't think we have very much ever. There's questions that offer that as part of the question. If you remember, it'll help you, but you'll be fine. Okay. Look, Trail Guide covers that the whole time it's there, so you'll see it 50 more times, and maybe you'll get it. It'll click at maybe at some point, you got 40 more weeks of class to get it. Okay, so triaxial, hint, hint, 3 planes and 3 axes of movement allowed. So think ball and socket, right? It does lots of different movements, like the hips and the shoulders, gliding joints with various planes. Okay, so we have all the different joint types here pictured. Condyloid, saddle, pivot, hinge, gliding, ball and socket, and their locations with the little color balls throughout the body. Okay, so kinematic chains at the bottom of 250. These are joints that are linked together, and motion at one of the joints has to happen. Motion has to happen at the other joint too. So a closed kinematic chain example would be ankle, knee, and hip. If you're gonna move the hip, you're gonna also have to move the knee and the ankle, even if it's a little bit. To sit down and move the hip, the knee has to bend, and the ankle is allowing movement as well. The angle of them is changing. that's a closed kinematic chain. They are closed in it together. They have to move when the other one moves. Open kinematic chain, these parts are free to move without movement. Another joint, such as the wrist. You can move the wrist freely without moving the elbow or the shoulder. You can move the fingers freely. You don't have to move the wrist. So that's the open kinematic chain. They're connected, but they don't have to move because their neighbor moved. Okay, and that's the end of what we're covering in this chapter. Isn't that enough? Okay, break time. And happens on 146, chapter 8.